This session is about papillary lesions of the breast, and I will start it by 3 case scenarios. The first case is about a 62-year female patient with right-sided bleeding per nipple. Her mammography showed right breast focal asymmetry with corresponding dilated ducts showing echogenic contents. By contrast enhanced mammography, there was a segmental non-mass enhancement. There was no malignant cell by cytology, and pathology revealed intraductal papillomas. The second case is about a 38-year female patient with left breast lump. Her mammography showed left breast circumscribed lesion. By ultrasound, there was a complex cystic lesion with intracystic solid component that showed heterogeneous enhancement on contrast-enhanced mammography, and pathology revealed encapsulated papillary carcinoma. In the third case, a 54-year female patient coming for screening, and her mammography showed this very small right breast spiculated lesion. That was confirmed by complementary ultrasound, and contrast-enhanced mammography showed faint enhancement. So pathology revealed invasive micropapillary carcinoma. 3 different pathologies, and they are all categorized as papillary breast lesions with different management options. So what are papillary breast lesions? They are a heterogeneous group of diseases characterized by the presence of epithelial proliferation supported by fibrovascular cores. And they are characterized by attachment to the wall of the ducts, extension into the duct lumen, the presence of the fibrovascular core, and those lesions with the lack of fibrovascular core are termed micropapillary carcinoma. They are rare tumors representing less than 3% of all breast tumors, less than 10% of all benign lesions, and less than 2% of all malignant lesions. Yet they have a good prognosis. They are categorized as benign, including intraductal papilloma and papillomatosis, atypical, including papilloma with atypia or DCIS, and malignant, which are either non-invasive, including papillary DCIS, encapsulated papillary carcinoma, solid papillary carcinoma, or invasive, like encapsulated papillary and solid papillary carcinoma with invasive component, invasive papillary carcinoma, and invasive micropapillary carcinoma. And there are many classifications for papillary breast lesion, either based on the location in the duct system, the nature of the proliferating epithelial cells, the presence and the location of the myoepithelial cells, and the morphology of papillary carcinoma. Based on the location in the duct system, they are either located within large ducts like a papilloma, encapsulated papillary carcinoma, or solid papillary carcinoma, or within the terminal ductal lobular unit as papillomatosis and papillary DCIS. Based on the nature of the proliferating epithelial cells, they are either hyperplastic as in papilloma, neoplastic as papillary carcinoma, or mixed hyperplastic and neoplastic like papilloma with atypia or DCIS. Based on the presence and the location of myoepithelial cells, in fact, the absence of intact myoepithelial cell within the papillary structure is an important marker for malignant lesions. And based on this fact, we can differentiate benign from malignant papillary lesions, and even specific subtypes of malignant papillary lesions can be distinguished. Concerning the morphology of papillary carcinoma, specific subtypes may present with a well-circumscribed margin, and these create a challenge because of the overlapping morphological features between benign and malignant papillary lesions, the difficulty in the diagnosis and the classification of certain papillary lesions, the difficulty in the differentiation between the non-invasive and invasive subtypes from the pathological and radiological point of view. So, the management of papillary breast lesion requires the collaboration between different specialties in order to achieve proper diagnosis and proper management. So what is the radiologist rule? He must identify the lesion and its location, spot the suspicious criteria, especially in those subtypes that can mimic benign lesion, assess the extent of the pathology, guide the tissue diagnosis, follow up of the diagnosed benign lesion, and he must have the knowledge about the imaging features of different subtypes, and this is the aim of our session. So starting with benign and atypical papillary breast lesion, first, intraductal papilloma. They arise from large central duct, more common in the perimenopausal females, and usually present with nipple discharge. On mammography, they usually appear as a well-circumscribed retroareolar lesion. On ultrasound, as a dilated duct with an intraductal solid nodule that showed a vascular pedicle on color Doppler. In this case, mammography showed a right retroareolar circumscribed nodule. By ultrasound, there was a cystic lesion, turbid contents, and intracystic nodule. Pathology revealed ductictasia with papilloma. Papillomatosis. They are usually peripheral, arising from the terminal ductal lobular unit, usually affect younger age group, and usually clinically occult or rarely present by a palpable mass. The imaging features are similar to central papilloma, differing only in location. But MRI may play a key role in the preoperative planning for patients with multiple nodular lesions to assess the extent of the disease. It is to be noted that multiple papillomas are more likely to be associated with high-risk lesions or malignancies compared with the central papilloma. This case, mammography showed left breast, retroareolar, and deeply seated focal asymmetries. By ultrasound, there were dilated ducts with echogenic contents. By contrast mammography, there were multiple enhancing nodules. The pathology revealed intraductal papillomas. Papilloma with atypia or DCIS. This entity describes a neoplastic population of cell within a papilloma. It is associated with evident increased risk of cancer. It may have similar features to benign papilloma, yet the presence of calcification may suggest the presence of atypia or DCIS. Diagnosis is by histopathology. Surgical excision is required when an atypical papillary lesion is present on core biopsy. There is up to 80% reported upstage to neoplasia. So the question now, whether to excise benign intraductal papilloma or not. It was reported that the frequency of post-surgical excision of benign papilloma range from 0 to 20%. Accordingly, some authors recommend the complete removal of the papilloma owing to the sampling error and the variability in distribution of atypia or carcinoma within a papillary lesion, while others recommended close clinical and radiological surveillance owing to especially in the asymptomatic patients and if there is imaging pathology concordance. And they stated that the risk of understaging may be decreased if multiple cores are taken or by using the VAB needles. Yet, according to several studies, upgrading of intraductal papilloma to malignancy may be associated with palpable lesions, larger lesion size, older age, peripheral lesion, higher BI-RADS score, pathological radiological discordance. And in this situation, surgical excision is recommended. In this case, mammography showed right breast central focal asymmetry. And by ultrasound, there were dilated ducts with echogenic contents. And the core biopsy, it was atypical intraductal papillomas that was upstaged after surgical excision to multifocal invasive carcinoma with major DCIS. Concerning the malignant papillary breast lesions, they are more common in the postmenopausal female, and they are either categorized into non-invasive or invasive. Starting with papillary DCIS, it is a variant from DCIS, yet associated with a higher rates of multicentricity and microinvasion and higher recurrence after excision. The extensive ductal spread and the underestimation of the non-calcified part of the DCIS may make it difficult to obtain clear margin on excision. So On mammography, the micropapillary DCIS may present as pleomorphic calcification in only a portion of the lesion. That's why it's very important. It may extend beyond the zone of the mammographically detected suspicious microcalcification, and this can explain the difficulty in obtaining clear surgical margin. In this case, mammography showed left breast focal asymmetry, and by ultrasound, there were dilated ducts mounting to mass formation with echogenic contents. By contrast mammography, there was corresponding segmental faint non-mass enhancement. And pathology revealed atypical intraductal papillomas with papillary DCIS. Concerning encapsulated papillary carcinoma, it is a papillary carcinoma within a cystically dilated duct, more commonly solitary and centrally located within a duct. Typically, it is a disease of postmenopausal women, and is the second most common breast malignancy in males. It can present as a palpable painless breast lump or a pathological nipple discharge. By mammography, it usually appears as a circumscribed solitary mass, by ultrasound as a complex cystic solid lesion, by MRI as a complex cyst with intracystic enhancing nodule or enhancing solid component. Encapsulated papillary carcinoma tends to bleed centrally, and color Doppler can show blood flow in these tumors, and this aid in their differentiation from blood clots. But please, in elderly patient with a large turbid cyst and intracystic echogenic soft tissue-like component, even with no depicted vascularity, is better to perform aspiration. If with bloody aspirate or if there is rapid refilling after aspiration, in these cases, should raise our suspicion. Also, it's important to include the wall of the mass in biopsy samples to distinguish encapsulated papillary carcinoma from an atypical papillary lesion. As with encapsulated papillary carcinoma, the surrounding fibrous capsule lack the myoepithelial markers. This case, mammography showed a hyperdense circumscribed lesion. By ultrasound, there was a complex solid cystic lesion, and pathology revealed encapsulated papillary carcinoma with no invasive component. Another case, right retroareolar large rounded mass with indistinct margin. By ultrasound, there was a predominantly solid lobulated lesion resembling phylloides tumor, and by contrast enhanced mammography, there was corresponding heterogeneous enhancement. Pathology revealed encapsulated papillary carcinoma with associated DCIS. This case, in the follow-up of this case, there was a developing cluster of microcalcification on the left side that showed enhancement on MRI, and pathology revealed recurrent papillary DCIS on the left side. Concerning solid papillary carcinoma, it is a rare entity that is composed of low-grade tumor that originate in large dilated ducts. Mammographically, it usually appears as a circumscribed or lobulated nodule or mass, and as encapsulated carcinoma, they are considered in situ carcinoma, despite the lack of peripheral myoepithelial cells in some cases. They rarely metastasize and are associated with excellent prognosis. In this case, mammography showed left breast lesion with indistinct margin, and by ultrasound, there was an intraductal lesion with increased vascularity, and pathology revealed solid papillary carcinoma. It's to be noted that in encapsulated or solid papillary carcinoma that are associated with invasive component, they should be staged according to the size of the invasive component. Please don't upgrade the stage of the tumor based on the mammographically measured size. This case, mammography showed a rounded lesion on the right side with indistinct margin. By ultrasound, there was a circumscribed hypoechoic lesion that shows a rather homogeneous enhancement on contrast enhanced mammography, yet with a linear non-mass enhancement, and pathology revealed encapsulated papillary carcinoma with a microinvasive component and associated DCIS. Though encapsulated and solid papillary carcinoma are considered as in situ disease, they are commonly associated with invasive cancer around the periphery of the tumor. They rarely show speculation, so the presence of focal irregularity or speculation should raise the suspicion of invasive component or associated invasive carcinoma. As in this case, mammography showed a large mass on the left side with a partially circumscribed margin and a partially speculated margin. And that was confirmed by complementary ultrasound and also contrast enhanced mammography that showed a larger extension to the retroareolar region. In this case, it was invasive ductal carcinoma associated with encapsulated papillary carcinoma. Concerning invasive papillary carcinoma, it is characterized by having a papillary architecture in more than 90% of an invasive tumor. It has a better prognosis with less axillary nodal metastasis and than do other forms of ductal carcinoma. In mammography, they appear as a lobulated or nodular density. Calcification are not evident despite the commonly associated DCIS. By ultrasound, mostly they are hypoechoic and irregular. This case, mammography showed a rounded lesion with indistinct margin. By ultrasound, there was a microlobulated hypoechoic mass, and pathology revealed invasive papillary carcinoma. This case showed two pathologies in both sides. On the right side, there is a large hyperdense speculated lesion, while on the left side, there was a small lobulated equal density lesion, and that was confirmed by complementary ultrasound. Contrast enhanced mammography showed enhancement in both, yet maybe more intense in the right-sided lesion. And pathology revealed right invasive duct carcinoma and left invasive papillary carcinoma. The last entity is the invasive micropapillary carcinoma. It is an aggressive variant of invasive carcinoma and usually associated with axillary lymph node metastasis and lymphovascular invasion. The imaging features are similar to any frankly malignant lesion with aggressive lesion. As in this case, the mammography showed a large irregular speculated mass associated with diffuse skin thickening and axillary lymph node, pathological axillary lymph node. On zooming, we can see the suspicious microcalcification within the mass and within the lymph nodes. And that was confirmed by ultrasound, the mass and the increased vascularity and the axillary lymphadenopathy. Contrast enhanced mammography showed heterogeneous enhancement within the mass associated with regional nodular mass enhancement. This case was a case of invasive micropapillary carcinoma with axillary lymph node metastasis. So, our take-home messages. The classification and the morphological imaging characteristics of papillary lesions remain challenging for pathologists and radiologists. Central solitary papilloma is usually benign and can be followed up, but if core biopsy revealed atypia, surgical excision is recommended to avoid understaging. Encapsulated and solid papillary carcinoma are in situ disease and rarely metastasize, yet if associated with invasive component, axillary lymph node assessment with a sentinel lymph node biopsy is recommended. Invasive micropapillary carcinoma is an aggressive variant and is associated with poor prognosis. And though imaging can help to differentiate the forms of papillary lesions, but surgical specimens are required for definitive diagnosis in the majority of cases. Thank you so much.
Thank you very much, Dr. Sherihan Fakhry, for this informative lecture. And we move now to Dr. Ashil